Managing minimal shunts, specifically small atrial septal defects and ventricular septal defects, is often an exercise in watchful waiting. While they don't meet the immediate QPQS more than or equal to 1.5:1 criteria for intervention, they aren't always entirely benign in the long term. Here is a clinical guide to identifying when minimal becomes concerning. Small ASDs, typically less than 5 mm, often remain asymptomatic for decades, but the risk profile shifts as the patient ages and ventricular compliance changes. Here are some red flags for follow-up. Right ventricular volume overload. Even if the defect looks small, progressive right ventricular enlargement or paradoxical septal motion on echo is a definitive sign that the shunt is hemodynamically significant. The aging heart effect. As patients develop systemic hypertension or diastolic dysfunction of the left ventricle, left atrial pressure rises. This can increase the left to right shunt across a previously negligible ASD. Atrial arrhythmias. New onset atrial fibrillation or flutter in a patient with a small ASD often suggests atrial stretching and may warrant closure to prevent further remodeling. Paradoxical embolism. Any history of unexplained TIA or stroke, that is cryptogenic stroke, makes even a tiny ASD or PFO a candidate for closure, though partly debated. A simple monitoring strategy may be, for adults, serial echocardiogram every 2 to 3 years if the right ventricle is normal. Exercise tolerance, annual assessment of functional capacity. Small restrictive VSDs, malady the Roger, maintain a high pressure gradient between ventricles, but the high velocity jet itself can cause secondary issues. Red flags for follow-up are aortic valve prolapse. This is the most critical worry for subpulmonic, doubly committed or perimembranous VSDs. The Venturi effect can pull the right coronary cusp into the defect, leading to aortic regurgitation. Any degree of new AR, no matter how small the VSD, is often an indication for surgical or device closure to prevent valve destruction. Double-chambered right ventricle or DCRV. The VSD jet can trigger the development of muscular bundles in the right ventricular outflow tract, leading to progressive subpulmonary stenosis. Endocarditis risk. While the risk is statistically low, the high velocity turbulence makes VSDs more prone to infective endocarditis than ASDs. Any unexplained fever requires blood cultures. Monitoring strategy is serial echocardiograms, focus on the aortic valve morphology and peak VSD gradient. A dropping gradient may ironically mean rising right ventricular pressures. Here is a summary of long-term hemodynamic impact. Primary risk in ASD, that is small ASD, is future development of right ventricular volume overload as discussed. In VSD, aortic valve damage or infective endocarditis. As a late complication, pulmonary hypertension and atrial fibrillation. In ASD, there is a possibility. In VSD, there is a possibility of double-chambered right ventricle or heart failure development. Clinical trigger in case of ASD is RV enlargement. In case of VSD, new diastolic murmur indicating aortic regurgitation. The closure pivot can be considered as QP by QS more than 1.5 in ASD, while in VSD, that is small VSD, development of AR or rising right ventricular pressures. In both cases, we must monitor for pulmonary hypertension. While rare in minimal shunts, its development changes the management from elective to urgent, or if Eisenmenger syndrome develops, contraindicated. Mean pulmonary artery pressure can be calculated as 1/3 systolic pulmonary arterial pressure plus 2/3 diastolic pulmonary arterial pressure. If you notice the VST gradient decreasing while systemic blood pressure remains stable, it is a sign of rising right ventricular or pulmonary pressures and warrants a right heart catheterization.